the subject is really what, maybe it's more personal thing, future treatment avenues and innovation. So where do I think we will go? Same thing. So if we think about what we want to achieve in acute stroke, we want to have a very high treatment effect in the individual patient. So theoretically, in all of the patients, MRS 0, so no symptoms after the treatment. And then we want to have access for all our patients, if they live in the center of Moscow or in whatever region of Russia, you want to treat all of them. Obviously, that will never be achieved. That's way too difficult. And we start somewhere here with maybe 20% therapy effect is already huge. And if we treat, let's say, 10%, 20% of all our stroke patients, already good. And this is where we were 2-3 years ago, with treating something like 4% of the stroke patients had a good outcome, Mr. Clean, like of 40%, Mr. 0 to 2. Then we moved to treat more patients. And then finally, we achieved better outcomes and maybe even more patients and more patients. And finally, we will go to MRS 0 to 1, maybe, as the next threshold. And how can we do that? That's how I see it. So we treated more patients because, as we just discussed, we can treat more patients because of later time points, basilar occlusions, low aspects, maybe also intracranial stenosis, distal occlusions. Imaging selection is actually less important than before. We were very strict with imaging selection before, but now with larger aspects, it's not so much. We achieved better outcomes with better modified techniques, so safe combined stent retriever, aspiration catheter, large bore catheter, better stent retrievers. Next step to more patients, drip and drive. We drive to other centers, do thrombectomy there. Going to talk about this. Then we have the training thing. So we train more interventionists, because for thrombectomy, we need way more interventionalists than we used to use for aneurysms and urofistulae and so on. And then finally, the next step from 0 to 2 to 0 to 1, modified rankings here, I think it's neuroprotection, I call it then flushing. So for instance, tenecteplase, as we just discussed, after the procedure, for instance, and also rehabilitation. And I would like to start with the modified technique as a development question. And one direction where we are going at the moment is the double stent retriever technique. So there is it seems to be it's definitely more complex to have double stent retriever, but the first pass effect and the distal embolization seems to be lower. And actually, we have currently a randomized trial ongoing. We are not involved, but others are, to use this double stent retriever. Industry will like it. It will double the cost maybe, but if there is a real effect, so it's worth analyzing. Then we have modified stent retriever design. So I have no shares or financial interest with these companies. But just to show you that this is a stent retriever from Japan, from Biomedical Solutions. It's kind of rotating when you pull it back. It's supposed to have a higher retraction force. And then we have this Vesalio stent retriever with this small basket distally that is supposed to capture more clots. There are others from Mivi that are supposed to do the same, just as an example. So there are still some developments in the stent retriever design that might show some benefit. And what's also promising is this technology with clot adhesive coating. So the stent retriever has a different coating that kind of captures with some biological methods the clot better. So this is has been published this year in the lab study, but this is something that's can become very interesting. So there's something going on, even with the stent retrievers technology. But then we have the fit between the catheter and the vessel and the large bore aspiration catheter. That's also an interesting subject. So we studied this a while ago, and we found out that the better the aspiration catheter fits into the specific artery, the higher the rate of reperfusion. So these are some ratios between the inner diameter and the outer diameter of the vessels and the aspiration catheter. And the closer they are, the better the primary aspiration success. And also has been analyzed with distal embolization. It is also beneficial to have an exactly fitting aspiration catheter. The next thing is from Vladimir Kalausek here. He analyzed the effect of cyclical aspiration. So it's not about the catheter. It's more about the way the aspiration force is administered. And they compared it with the other studies, and it looks good with this technology. But that's very early. But I think it makes a lot of sense to modify the aspiration as well. Okay, next subject to expand what we are doing is logistics. So we heard about it from Dr. Savello already in his previous talk on his huge achievements in St. Petersburg. And this is Germany, and the coverage with thrombectomy rates in the different regions. And you see what happened between 2016 and 2019. So there was a huge expansion in the coverage with thrombectomy. So currently we do approximately 10-12% of all ischemic strokes in Germany are now treated with thrombectomy. And how do we do that? So we heard about in Dr. Savello's talk about the mothership. So you have the patient comes to the hospital with the angiography machine, and the trained interventionalist is there all together. Then you can do it in a different way within the hospital, not just to skip the CT. You don't do a CT imaging. And this is a randomized trial from the colleagues in Barcelona. And they went direct into the angio without CT for acute stroke. And the result was that it was the clinical outcome was better if they skipped the CT instead of doing a CT first. So I think we are going to go in this direction, further speeding up our procedures by going directly into the angio. Then we have this drip and ship method. And then something what we pioneered is the drip and drive. So we go to a different hospital and do thrombectomies there. If you think about it, there are, you can model the time. So this is a bit difficult to explain. So let's say this is where the patient is, somewhere in this, along these lines. And if the patient is here, then here's the endovascular center, and then there's the non-endovascular center, and the patient is somewhere on this circle. And if he's behind the non-endovascular center, it makes sense to get drip and ship, so to get IV TPA first. But if he is in the green region, it doesn't make sense to go back to the non-endovascular center, receive IV TPA, and then go to the endovascular center. So this would be a detour. And this is what we simulated in Hamburg. Hamburg is in north of Germany, what you see here. And we have the region where it's green. This is where the patient should go directly to us in the middle. This is a mothership. And then if the patient is more remote, like in this violet regions, the patient should do drip and drive, go to the other hospital first. receive IV TPA and then go to our center, and then there is this drip and ship region. So this is dependent on the time of the day. Let's say in the morning, 1 a.m. at night, drip and drive would be the best thing. So we go to the other hospital because it's very quick. We go to the other hospitals, mothership, the green ones, the patient comes to our place. And at 7 a.m. in the morning, when all the traffic goes to Hamburg, here in the middle, it would be very difficult to get the patient in on time. So we would go to the patient in this violet region because we are against the traffic. And then, believe it or not, 6 p.m. looks completely different. So the point that I'm trying to make is I think in the future, we will have a much more flexible system of patient transportation dependent on the traffic and the time on the day, and maybe in real time shifting. So this is, I think, very interesting to think about. This is where we can make great gains for the patient. We can save 1 hour, 2 hours of travel time if we do the right thing at the right time. Next subject is training. So there's a study in 2016-17. It has been published in 2019, but it's covering the time 16-17. This is about a survey in Europe. So 2% of all strokes received IV TPA at that time. And what was the main reason? The main reason was that there was trained personnel was lacking. So we didn't have enough interventionalists. And there is an update to this survey. It's not published yet, so I cannot talk specifically about the numbers, but there is a higher caseload now. There were other problems in the meantime, like COVID. We lost quite a few technicians, nurses, wider indications, and there is still a perceived lack of specifically trained personnel. So how can we do that? And this is what I would call telementoring. This is what we are interested as well. Let's assume you are on a place where you have no high-end neurointerventionist, but maybe you have somebody who has had some training, and you can support this person if he runs into trouble with a remote connection. So this is how we do it. So this is a specific system. It's from Tegos. This is used also in the e-fellowship of the ESMINT. And this is how it looks like. It's relatively small, and you can connect to the angio suite with your proctor. So this is how it looks like. Very, very small, yeah. And you can zoom in and zoom out. It's very easy to use with some presets. It's very intuitive. And this is the type of resolution that you can get. You can see much better. Just imagine you would stand next to your colleague. You see much more with this system than you would see in reality. We did a pilot study on this, and there was exactly local advisor in the room, remote support, same duration of the procedure, same amount of contrast, same fluoroscopy time, and so on. And this is an interesting example from Bonn, Germany, and how they are training the young fellows in thrombectomy. So they require 20 hours with a simulator, virtual thrombectomy training. Then they do 15 thrombectomies with on-site supervision. So you are in the room as a trainer. And then the next 15 thrombectomies, they are supervised using this Tegos machine. And this is how it's perceived, the benefit of the system. So this is the first intervention. This is the 15th intervention. And it goes down. In the beginning, you have a high benefit with this remote proctoring. And after 15 procedures, not so much anymore. And I think that's a nice development, how you can speed up the training so you don't need to be there for these second 15 thrombectomies yourself. This is the team of the Esmond E-Fellowship. Currently, we are at the 3rd season where young fellows can look into the planned and into the emergency procedures. And I think we also have a Russian fellow participating in this program. And you see there are a lot of very well-known people here. For instance, René Chapeau is participating and so on. Vladimir Kalausek won the prize for the most streams. So I think he had his presentation yesterday. And I think this is just an analysis. I don't want to go into details with this about where is the most value for the participants. So what about robotics then? So do we really need to do remote proctoring if we do it by robotics very soon? And this is, I don't know if you are all aware of this information. Last week on Wednesday, it was announced by Siemens that they would stop their cardiovascular robotic program with Corindus, and they would develop the neurovascular robot from the scratch again, or almost from the scratch. And this is what they said. So the timeline for robots for neurological operations will take several years. So the market leader at the moment, Siemens/Corindus, they stopped it. Other companies are also working on it. Obviously, that's not the end of the world, but I wouldn't expect robotics taking over in the next 2, 3, 5 years. So this is a bit of a bummer. So, and my final subject is, how do we get from 0 to 2 to 0 to 1? And this is, I think, interesting from a trial perspective as well. So we have here the choice randomized control trial in Barcelona again, where they selected patients with TICI-2B, so TICI-2B3 essentially. And even if it was almost complete or even complete, they injected distal to the origin of the lenticulostriate branches in the MCA. They injected alteplase, so TPA. And the result was like this. So they had a better outcome. It's a kind of flushing after you think you are done, but you give a little bit more TPA still, and it added another 18% with MRS 0 to 1. And if you look at this 0 to 1, there is a difference. But if they had chosen 0 to 2, there wouldn't have been a difference. So I think it's really for the final bit of improvement of the patients. That's an interesting observation. No increase in hemorrhage in this study, but it's a small study. Let's see how this develops. So we will have the tenecteplase studies, the techno study, and so on. Neuroprotection, that's also a very long story for many, many years. It's a story with a long and disappointing history. It never worked in human. It worked always in mice and rats, but not in human. But now we are in another era with high perfusion rates, and I think that's the difference to before. For neuroprotection, you need to have reperfusion first, and this is what we have now. We have this ESCAPE NA1 study that showed that in patients who didn't receive IV TPA because of contraindication, you have an effect, a neuroprotective effect of neridutide, so NA1, of approximately 10%. But it doesn't work at all if you give alteplase additionally. Obviously, you cannot remove alteplase, but in the subgroup of patients without alteplase, it seems to work. And they finished already the ESCAPE Next study in January. And the results are going to present it also this year. And I would be surprised if it wouldn't be the first positive neuroprotective study in acute stroke. So wait for that. Then we have other things on the endovascular route like this, maybe could play a role in the future with rehabilitation. This is an interesting study this year published in JAMA from a group in New York with this stent road. It's a brain-computer interface. Interesting to look at. So to summarize what this, if we look at the development and where it could lead to, so number one, better treatment results in the individual patients, so better stent retriever. Then we have this flushing thing going on with TPA, tenecteplase. Neuroprotection might work for the first time. We will learn this year. And then maybe rehabilitation, for instance, the stent road stent would be interesting. And then the patient access, more training. So ever wider indication. We talked about large core and so on. Logistics, direct to angio, real-time drip and drive changes dependent on the traffic, and better training of interventionalists, remote mentoring, e-fellowship as an example. Thank you.